So this is week 2 for the pediatric nutrition portion of your course. The learning objectives for this week are to learn the basics for the NFPE or Nutrition Focused Physical Exam, to better understand Z-scores and how they apply to anthropometric measurements and assessments and the diagnosis of pediatric malnutrition, to utilize the malnutrition criteria to diagnose pediatric malnutrition, and to utilize equations and growth charts for catch-up growth. Also, there will be a basic review of micronutrient supplementation, some other growth charts you might see, and some unique Alaska pediatric challenges as they relate to nutrition. So, the NFPE. You should be familiar with the nutrition-focused physical exam from your work on adults. For pediatrics, it is a crucial component of nutritional examination. There's an article on your dashboard that is required reading for week 2 that goes over the NFPE in more depth. But what it helps us to do is identify or confirm muscle wasting, subcutaneous fat loss, edema, and micronutrient deficiencies. Some of the nutrition-related signs and symptoms found during clinical examination can later be more objectively confirmed with laboratory assessments. Dietitians should take responsibility along with the help of the multidisciplinary team to perform the NFPE assessments. For help doing this, you could look to the bedside nurse or another RD. When performing the NFPE, it is important to use good judgment not only in pediatrics, but for all patients. It is sometimes not appropriate to perform an NFPE. Some examples of this are if a patient is intubated, sedated in the ICU, has poor pain control, is post-op, or a child that exhibits fear of strangers or providers. In these cases, you may use a general visual assessment and note the inappropriate timing of performing an NFPE and that you will do it when the timing is appropriate. Another thing to consider again is the climate of our world. It's best if you can to ask parental or caregiver permission prior to performing an NFPE. For yours and the child's protection, it's best to have an additional witness in the room. Make sure that you use proper hand washing and sanitizing techniques per your facility recommendations and that you follow infection control barriers that are likely posted on the room. So let's move on to the steps performing a basic NFPE. First is the general survey. That means the overall appearance, alertness, demeanor, body habitus, and size. Is the patient wasting? Is he cachectic? Are they obese? Basically, it's how the patient looks. Moving on to skin, you want to inspect the skin surface in a good light. Look at the color. Is there hyper or hypopigmentation, redness, cyanosis, jaundice? And what about moisture? Is it dry? Is the patient sweating? Is the texture rough or smooth? How is the temperature of the skin? Are there lesions noted? And how is the skin turgor? For the head and the hair, inspect the scalp and hair quantity, the distribution, texture, color, and if the hair is falling out. Also assess and rate the temporalis muscle. For eyes, ask if there are changes in dryness or night vision. Observe the color of the sclera, conjunctiva, and the cornea for foamy white spots. Assess the fullness and color around the orbital region. For the mouth, observe moisture, swelling, color, dentition, lesions around the extra and intraoral cavity and the lips. Check the corners of the mouth, tongue, mucous membranes, gums, and teeth. Ask if taste changes are present. This is important in a patient that perhaps is on chemotherapy and will, of course, affect their ability to eat and their nutritional status. For the neck and upper body, inspect the neck for masses, i.e. looking for a thyroid issue. Assess for muscle and subcutaneous fat loss in these regions. that include the clavicles, the shoulders, scapula, ribs, and triceps. For hand and nails, inspect hand and nails for color, texture, shape, and lesions. Palpate the interosseous muscle for fullness and distribution. For the musculoskeletal system in the lower extremities, observe the overall muscle appearance. Ask if strength, movement, swelling, or painful joints are present. Observe for bow legs and knock knees. Inspect and palpate the quadricep and calf muscles. Also rate edema around the ankles. Once you have your NFPE findings, you can move on to interpretation and reporting. Just a quick note, remember when you are charting to be brief. If there wasn't a problem, you can simply chart no indicators present, or if there was a problem, focus on that specific problem and not reporting the entire physical exam. That would be exhaustive and probably take several pages. The chart below is found in your dashboard in the resources, and you can use it not only for children but for adults as well. I found it to be quite helpful, at least to point you in the right direction. I won't read through this entire chart, as I assume being in the master's program, you guys are really good at reading. I will say that probably the most common deficiency I found, especially in Alaska, is iron. For iron deficiency anemia in our toddler population that may drink milk all day long. I have seen pallor and definitely the spoon-shaped nails. Another thing that you may see commonly here in Alaska, and it isn't noted in the chart, is vitamin D deficiency and the evidence of rickets. If you walk downtown, just take a look around at the population and you'll find that more exhibit signs and symptoms of rickets than you'll see in the lower 48 per se. This is where it's important to compare the findings of your NFPE to your diet history and look for a correlation in what you're seeing physically versus what they're taking orally. An example of this is a child in the village who may be isolated and not have access to many fruits and vegetables. Are you seeing evidence of this in the NFPE and the diet history? It's just something to think about as you're performing both. So on to understanding Z-scores. What are they? There's an article diagnosing pediatric malnutrition that's required for week 2 that covers Z-scores a little bit more in depth. For a simple definition, it's simply a statistical designation of standard deviation from the mean. It doesn't only apply to nutrition, but is used in statistics in general. In looking at the bell curve below, you can see for the standard deviations, the numbers -4, -3, -2, -1, 0, +1, +2, +3, and +4. Those are the Z-scores. And above that, you can see the population distribution that falls into those Z-scores. Below, you can see the percentiles that are equivalent to those Z-scores. For example, a Z-score of 0 is at the 50th percentile. A Z-score of -1 is approximately at the 15th to 16th percentile. A Z-score of +1 is approximately the 85th percentile. And that's how we use them to correspond to the growth chart percentiles. Just to reframe it, and as an example, a Z-score of 1 represents a score that is 1 standard deviation greater than the mean. A Z-score of -1 represents a score that is 1 standard deviation less than the mean, etc. A standard deviation of -1 to 1 would include about 68% of the population. A standard deviation from -2 to 2 includes 95% of the population. And from -3 to 3 would be 99% of the population. The easiest way to calculate your Z-scores, once again, is to go to PediTool and plug it into the appropriate growth chart, or the EMR in your health facilities will have it calculated often as well. To find it, you simply hover on the dot that's on the growth chart and it should pull up the percentile and the z-score. There are percentile conversion charts available online should you choose to go that route. So why use z-scores? First, the WHO recommends using z-scores to track anthropometrics. Z-scores allow for more precise measures than the customary placement of near or below a certain percentile curve. Using z-scores allows comparisons against one's own trend, as they can be analyzed as a continuous variable in studies. As an example, everyone's z-score trend is unique to themselves. So a child could be trending at negative 2.5 z-score in weight, and your goal might be to get him greater than negative 2. Well, that's easy to see as he progresses upwards to say negative 2.4, negative 2.3, negative 2.1, and then finally negative 2. It makes more sense to track it that way versus saying he's improving from the 20th percentile to the 21st to the 23rd. That's a lot of numbers to have to keep track of. Z-scores also recognize the variation in weights at one height may be different than at a different height. It also improves identification of change in status. In the previous example, a z-score improving from a negative 2.5 to a negative 2 would be an easily identifiable improvement. One nice thing about z-scores is that you can quantify the extreme growth status at both ends of the distribution. If you are on the charts and the patient is above the growth chart, all it will say is greater than the 99th percentile, or if they are less than the 3rd percentile or the 1st percentile, all it will say is less than the 1st percentile. Z-scores continue to go up or down. So say I plot an infant who was born prematurely on a standard growth chart. Their weight z-score may be negative 4 or negative 5, which you can commonly see. Or an older child who is developmentally delayed, their z-score may also be down in the negatives, negative 2, 3, 4, 5, and lower. Say you have a child who is obese, that z-score might be positive 3, positive 4 for weight, which also indicates a problem. It's not just being below the negative 2, 3, 4 z-scores. Also having a high z-score can indicate some nutritional concerns as well, obviously. So how do we use z-scores to classify nutritional status? The first thing to note is that classifying nutritional status doesn't necessarily mean diagnosing malnutrition. The normal range on all of the z-score values is considered to be negative 1 to positive 1. So if you look at the weight and go to classify what that might indicate, a z-score of negative 0.6 is in the normal range, or a z-score of positive 0.6 is in the normal range. If the z-score were to drop to negative 1.5, then that might indicate that the child is marginally underweight or possibly mildly malnourished. And moving on to height, once again, the same principles apply. Between negative 1 and 1 is considered a normal height. What we're concerned about in height is a lot of times children with chronic diseases such as chronic lung disease or congenital heart failure are often stunted. So you'll see their z-scores down around negative 2, negative 3 consistently. And that shows a lack of nutrition during some pretty intense medical treatments during their life. Another big problem is that these kids probably have been on steroids, and steroids are notorious for stunting growth in children. The weight for length z-score for children under 2 or the BMI z-score for children over 2 is actually an extremely valuable tool. This measures the child's weight against their own height. So say the child had negative z-scores for weight of -2 and negative z-scores for height of -2. Those don't look so great on paper, but their weight for height z-score may be within normal limits. And you have to consider that when you're dealing with populations that are diverse like Alaska. Say you have a smaller child of Asian descent, that child is likely to plot low on the growth chart simply because that's his genetics. Or if you have a child of Samoan descent, you expect those kids to plot a little higher on the growth charts. If their weight for length z-scores and their BMI z-scores are within normal limits or relatively close to those normal limits, then they are in good shape for their own body. So that's a really valuable one to achieve, and why getting an accurate height is so frustrating sometimes, because we do rely on that to see if they are growing properly and proportionally. If you do have a weight for height or BMI z-score that is low, that indicates wasting, severe wasting, and it becomes one of the criteria for malnutrition, which we're going to move on to next. So, when diagnosing pediatric malnutrition, it factors in z-scores, anthropometrics, and diet history. You can see an article regarding diagnosing pediatric malnutrition, which is in your dashboard and required reading for week 2. To make the diagnosis, the patient must fit into parameters to receive an official billable diagnosis of malnutrition, and most hospitals, medical facilities will hound you for documentation if you have made that diagnosis without the child meeting criteria for malnutrition. Of note, this criteria applies to children who are greater than 1 month of age through 18 years of age. Pediatric malnutrition in the neonate is in the works, and we expect to see that rolled out around here probably within the next year. Also, this doesn't apply to babies within the first 14 days of life, as we expect a natural drop in their weight, and their goal is to regain weight by day of life 10 to 14. If the patient doesn't meet criteria, that doesn't mean there aren't deficiencies or increased nutritional risks. You just have to follow along closely, and if it's appropriate to diagnose malnutrition in the future, go ahead and do it. Or if you have diagnosed malnutrition and the patient has improved, it becomes part of their past medical history, and you report an improved nutritional status no longer meets criteria for malnutrition. So here are the parameters for diagnosing pediatric malnutrition. You can see that the top chart are indicators when a single data point is available that is one of these: a weight for height z-score, BMI for age z-score, length, height for age z-score, and a mid-upper arm circumference z-score. If the patient's weight for height falls into one of the negative categories, then you would classify it for that particular category. So say the child had a weight for height z-score of -2.5. That patient would be classified with moderate malnutrition. If you had an older child whose BMI, say, was in the -3 to -3.5 range, that child would be classified with severe malnutrition. The second chart plots when 2 indicators are present. Say you can't get an accurate height. You can't get an accurate picture of what their BMI is. So you can look at things like weight gain velocity, weight loss, a deceleration in weight for length z-score, and inadequate nutrient intake. And you have to prove 2 of these to meet criteria for malnutrition. For weight gain velocity, say that I had an infant who was not growing well and only gaining 10 to 15 grams per day versus the expected 25 to 35 right after they are born. I could take a point on the chart a month ago and the current weight today and make the calculation based on that number of days to come up with a number which then I would divide by the goal to give me a percentage of the expected or usual weight gain. That oftentimes will get children a criteria point when they're less than 2 years old. As far as weight loss, you can see that to classify mild malnutrition, it's 5% usual body weight, moderate 7.5%, and severe is 10.5%. One thing to note is that if the child is unable to give a diet history, or if you are unable to speak with someone about the child's nutritional history, often you can make that leap to assume that inadequate nutrient intake did take place in order for that weight loss to have occurred. So I will make the diagnosis if I feel like it was probably the case that the child didn't get enough to eat, therefore that resulted in weight loss. For a deceleration in weight for length and height z-score, that just means that the z-score is no longer following an appropriate curve. It is indeed falling kind of off the curve. So say the child had a BMI of -1 and had been trending at that for a good portion of their life. And all of a sudden they have an acute illness or a chronic illness or problem, and their z-score declines to -2.2. Well, that's a decline of about 1 z-score, so they would qualify for malnutrition, mild. If the z-score dropped, say, to -3, then that becomes moderate malnutrition. If you have points on this chart where, say, one meets mild malnutrition and your second point meets severe malnutrition, then it's best to average in the middle and say moderate. If one is moderate and one is mild, then use your best judgment to determine where that child really is. Once you diagnose malnutrition, you do have to put in the common etiology, where did this come from, diagnosis statement. So you would say something like, meets criteria for moderate malnutrition in the setting of chronic illness or social factors or whatever applies in that particular child's case, as evidenced by weight gain velocity less than 75% expected for norm, and deceleration in weight for length z-score. Or if you were using the top chart, then you would say meets criteria for severe malnutrition in the setting of chronic illness based on BMI for age z-score of -3.5 or whatever it happened to be. So that's how you classify and write your malnutrition statement that should go in the chart so that the coders can see that and go ahead and bill for it. To correct an earlier comment, weight loss for severe malnutrition is 10% and not 10.5%. And when you are classifying malnutrition, acute is less than 3 months in duration and chronic is over 3 months in duration. And just as in adults, you can say acute on chronic illness because that can be a factor. You might have a child with cancer who is chronically malnourished now, who admitted with rhinoenterovirus and is acutely ill. So it is appropriate to say that as well. If the child does meet criteria for malnutrition, go ahead and make the diagnosis. If he does not fit into the parameters, document nutritional risk and indices that the nutrition team is following. Just because he initially didn't meet criteria doesn't mean it won't progress as he stays inpatient to malnutrition. There are some unusual circumstances that may affect a malnutrition diagnosis. Something like fluid shifts, which is probably the most common seen, where you have someone that's admitted severely dehydrated or they've been fluid resuscitated and gain an enormous amount of weight in a short period of time. So you really have to take a look at the fluid status and make sure that the weights you are using are relatively accurate. Another thing that is more commonly seen in children than adults is developmental delay. In that case, it's very difficult to get a height on those kids, and often their needs are much less than the standard kids. So you have to look at the overall picture for them. They may only be on a tube feeding that's providing 5, 6, 700 calories per day. So technically they aren't meeting their needs for their age, but that may be what their needs are per disease state. So often when I make recommendations for them, I will use calories per kilo based on home regimen. But it's something you have to take a look at because there are definite malnutrition concerns for that group of patient. The last factor you might want to take a look at is any issues that you have with measurement devices. Was the bed zeroed out? Were you able to weigh a developmentally delayed child in a Hoyer lift? Do you trust the anthropometric tools that were used to measure? All of these can affect making a malnutrition diagnosis. So, moving on to catch-up growth. Once again, there are many different ways to calculate estimated needs to promote catch-up growth. The ones I'm recommending are the easiest, and more importantly, they work. The first is to use the weight age. If the child falls between the 20th and the 80th percentile, I would just use the estimated needs that we discussed in the previous module to determine that child's estimated needs. If the child is less than the 20th percentile or greater than the 80th percentile, I would go ahead and use weight age. If he's less than the 20th percentile, you find the weight on the chart, then follow left along that weight line to the nearest 50th percentile. Then you go straight down to find the age. You use this age for his estimated needs. If the child is greater than the 80th percentile, follow right along that line to the 50th percentile, then straight down again to find the child's age. And you use this age for estimated need calculations. There is an example of this on your dashboard. It's a little easier to read than something I would have put on this presentation. You can see it, you can handle it, you can move your finger around and see how that works. But I like this for catch-up growth. I find that it's closer to a true estimation of what that child needs for growth. Another method to use for catch-up growth is to determine the ideal body weight, which is the weight at the 50th percentile for that age. You can then use that age to determine the estimated needs and add maybe 5 to 10% if you feel like it's warranted. One of the problems I've seen with using this method is it tends to overestimate the energy needs a little bit and can lead to an overfeeding. For both methods, they require regular anthropometric monitoring to assure that over and underfeeding are managed. And you need to set realistic expectations. Catch-up growth can take a significant amount of time. And since the goal is to get the BMI or the weight for length to a z-score range of -1 to 1, this is something you're going to want to watch. The other thing to remember is that catch-up growth for height is much slower than catch-up growth for weight. So a more moderate approach is recommended with close monitoring to avoid overfeeding. Just as an example, in a child that has congenital heart disease, the tendency is for the child to grow poorly on both parameters, both weight and height. All of a sudden, the metabolism seems to figure itself out, and they start to gain weight rapidly and what appears to be normally. The doctors get really excited about this, but forget to look at the height, and the height is not keeping pace. It's increasing at a much slower rate. So what you end up is with a child that has a weight for length or a BMI well above the z-scores you would like to see for that, and basically you've made a square. That's what we like to refer to as a short, boxy, little obese person that we've created from overfeeding. Lastly is to remember to monitor for refeeding syndrome. If the child is at risk, advance nutrition recommendations slowly, and there are a specific refeeding protocols that are available. And go ahead and monitor your usual labs, the K, phos, mag, calcium, and glucose, and consider thiamine supplementation. I'm sure you've discussed refeeding in other portions of this course. So if you do have any other questions, go ahead and ask them. It's very similar in children as it is in adults. Now to move on to tying up some nutritional loose ends. For micronutrient supplementation, I generally recommend an age-appropriate daily multivitamin with or without iron that follows the RDA or DRI guidelines. There are many available on the market that generally meet these requirements. When it comes to micronutrient supplementation, that needs to be individualized, and I've provided some reference charts for you back in week 1 that show what age appropriate requirements are for the micronutrients. If you have any questions, it's best to use a pharmacist, either inpatient or outpatient, to determine appropriate product and dosing, as once again there are many different options available in stores and on the internet. We want to make sure that the child receives the best bioavailability possible in the appropriate dose. So on to growth charts and estimated need modifications. There are some other growth charts that you may see in your career as a pediatric dietitian. In fact, there are many of them. Some of the more common ones you will see are for preterm, the Fenton and the Olson charts. I like the Fenton charts because it goes all the way up to 50 weeks of age, which makes it nice. Starts down at about 23 weeks of age. A few other common charts are the Downs, dwarfism, developmental delay, and CF charts. The last 4 are limited by populations used to assess them and are more frequently used by specialists in those areas. So personally and professionally, I plot them on standard charts, knowing they will not be in the normal range. But I can track their z-scores to assess appropriate growth. For some modifications to estimated needs, see your nutrition assessment cheat sheet from week 1. This contains some adjustments for cystic fibrosis, developmental delay, Downs, and then protein modifications for renal diets. I use these because the estimated needs for cystic fibrosis are so much higher than the general population needs, and for developmental delay and Down syndrome, they are generally lower than the general population needs. For renal disease, the protein needs are modified based on whether they are on dialysis or not and severity of the disease. These honestly are the only specialty modifications I use generally, and then I can avoid using complicated equations that I may or may not have accurate anthropometric data for. Finally, moving on to some of our uniquely Alaskan nutritional challenges. I've mentioned previously that Alaska has a very diverse populations. We have Asians to Pacific Islanders to Native Alaskans to Africans to Eastern Europeans. We have it all and everything in between, which means we need to account for this in our nutritional plan of care. Another thing to look at is the geographic isolation. Villages often develop genetic disorders, some with nutritional implications that are passed down from generations to generations. One of the most common ones that we see is an isomaltase sucrase deficiency, which means that the child can't properly digest sucrose. So in a baby, it's kind of interesting. We talked earlier about lactose deficiency problems. Well, if there are sucrose or sucrase digesting problems, we actually have to go back to a standard term formula that contains lactose for the baby to tolerate it. Our food supply in Alaska can be challenging. Once again, the geographic isolation plays into this, and certain villages are more susceptible to micronutrient deficiency due to unavailable foods, or perhaps they focus on one food. And finally, our wonderful fluctuations in light contribute to all sorts of vitamin D problems. Basically, vitamin D supplementation should be recommended for the entire state of Alaska. And that's a wrap for this portion. Congratulations on finishing the basics of pediatric nutrition assessment, plan of care, malnutrition, and NFPE. Next week, it's on to critical care and the PICU. Once again, pediatric nutrition is a whole new world in some respects and can be overwhelming. Don't stress if some of the information doesn't make a lot of sense. The goal for this portion of the course is that you know the basics should you encounter it in your practice, whether inpatient or outpatient, WIC, school, etc. If you have questions, don't hesitate to reach out to a pediatric nutrition specialist. And if it's something you're interested in, pursue it. Being a pediatric dietitian has a great impact on a child's life, and you make a big difference. It's a career path that I feel I've been lucky to walk down all the way to the NICU. So we'll see you next time for Module 3. Good luck!